Hello, this is Dr. Homerayo. I'm going to be talking today about the immune hemolytic anemia. It's part of the module 16 on your VBT program. These are some of the readings that are going to be part of this program. The mandatory ones, as you can see, is the Howard Chapter 8. And there are some optional readings as well that will help you understand better this information. First, I want to start with the normal physiology. As you may already know, normally the red blood cells or erythrocytes have a lifespan of approximately 120 days before being removed by the spleen and other organs. Erythrocytes coated with worm-reactive autoantibodies are sequestered and phagocytized by macrophages, primarily in the spleen. The severity of this type of anemia is determined by the lifespan of the red blood cells and the rate by they are remade by the bone marrow or replaced by the bone marrow. You can see an image here on the right where you see a normal red cell. When they have attached IgG or complement, they may be again detected by macrophages and they're clear up, and they may become spherocytes or microspherocytes when they go through the sinusoids in the spleen and the liver. Looking at the statistics, the incidence of autoimmune hemolytic anemias has been estimated about 1 in 100,000 per year in adults. The majority of them are warm autoimmune hemolytic anemias. 50% of them are classified as primary, 1 in 80,000 in general population, and the peak incidence is between the 6th and the 7th decades of life, and it's more commonly seen in women than men. When we look at the classification of the hemolytic anemias, they can be grouped into autoimmune hemolytic anemias, alloimmune hemolytic anemias, and drug-induced immune hemolytic anemias. In the autoimmune classifications, you will have the warm autoimmune hemolytic anemia, the cold agglutinin syndrome mixed type, paroxysmal cold hemoglobinuria, and DAT negative autoimmune hemolytic anemias. In the autoimmune version, you may have hemolytic transfusion reactions or hemolytic disease of the fetus and newborn, which are topics during your training. And in the drug-induced hemolytic anemia, you may have drug-dependent and drug-independent. When we define the warm autoimmune hemolytic anemias, it's basically the shortening of the red cell survival by the product of immune response or autoantibody in these cases. If the bone marrow is able to adequately compensate the reduced red cell survival, this may not result in anemia. The autoantibody is usually an IgG, but it can be also other types like IgM or IgA. And in this graphic also you can see the image of how they look like IgM is the largest one with the pentat, IgA is the second largest one with the two IgA connected together with the joining chain and the secretory protein. The causes, it could be primary when we don't know the cause basically, or it's idiopathic, also called idiopathic. The other group are going to be secondary to common diseases association. Most of them are hematologic malignancies like lymphoma, leukemias, also autoimmune disorders like lupus, or chronic inflammatory conditions like Crohn's disease, ulcerative colitis. Also, ovarian tumors and medications like methyldopa and procainamide have been involved. Warm autoantibodies, the more strongly reactive they are, the more likely are to be associated with overt hemolysis as well. Similarly, warm reactive auto-IgG are also associated with complement C3d on the red cell membrane, and are more likely to be hemolytic via the synergistic effect. So both of them will act together to create more hemolysis. The clinical significance, in order to determine this, a number of ancillary laboratory tests can be used, including hemoglobin and hematocrit, which usually are low. Reticulocyte count, in general, if the bone marrow is working well, it will be elevated. Lactate dehydrogenase, or LDH, will be elevated since the red cells are being destroyed. And indirect bilirubin as well is going to be elevated for the same reasons. A visual inspection of the plasma or urine can provide helpful information as to whether the hemolysis is present is intravascular or extravascular, which is the most common one. It is advisable to assess the red blood cell morphology on review of the peripheral or of the peripheral smear, because spherocytes are typically identified in cases of warm autoimmune hemolytic anemias. And in this background slide, you can see this is a normal erythrocyte with a central pallor, and then you see a row here with an arrow as well of a spherocyte. So that red cell lost part of the membrane when they went through the spleen and liver, and the macrophages chew up part of their membrane that had attached IgG or immunoglobulins or complement, and that's how you can see the cell become smaller and the central pallor is gone. Well, and what is very important in these cases is to have a good medical history, since all antibodies form as a result of red blood cell exposure via transfusion or pregnancy most of the time. And it's an important task for the blood bank staff to obtain this history. And we know it's very hard sometimes to get that from the clinical side. If a patient has been transfused or has history of pregnancy, and there is time, the safest practice is to complete an absorption study before transfusing. It is critical to communicate with transfusion services that they may have evaluated the patient in the past, so we have more history. This is a sample from our forms for request for immunohematology services, and you can see the arrows pointing at some places that we usually miss in the history, like diagnosis, medications, current hemoglobin, transfusion history, and any known RBC or platelet antibodies. So all of this information is critical to get to a better conclusion on the studies. Looking at the lab studies, the patient experiences hemolysis to the extent that transfusion support is necessary, additional serologic work may be necessary. These studies may include the cross-match, absorption studies, phenotype or genotype, and elution. We'll look into this further. When we talk about cross-match, cross-matching excessive number of units to identify those that are least incompatible provides no proven clinical benefit for patients in these cases, since they're going to be basically all incompatible when you have this kind of warm autoimmune hemolytic anemias. The incompatible units associated with warm reactive antibodies should be transfused judiciously, knowing that as long as the antibodies have been investigated, these units should have the same survival as the patient's own red blood cells, even if it is diminished. Autoantibodies with defined specificities, the warm antibodies typically react with all reagent red blood cells with the same general strength of reactivity. However, they less commonly demonstrate some specificity for a blood group antigen in a relative or absolute sense. To confirm the autoantibodies have an RH specificity, then some of the options may be testing them with rare RH null or D-red cells. These are polyclonal immune responses. And you can see in the image here in the background, stomatocytes. So this central pallor now becomes like slit-like or mouth style. This can be seen in patients that have the RH null type, blood type. Autoantibodies with weakly or non-reactive DATs. In cases of hemolysis, but DAT is weakly or non-reactive, there are immunologic and non-immunologic causes for this. We list a few of them. Drug-associated hemolysis. It could be hemolysis due to IgA autoantibody. It could be the Donner-Landsteiner autoantibody with anti-P most commonly. Warm reactive autoantibodies with unusual thermal amplitudes, or something that is non-immunologic related is the hemolytic toxin or the spider venom and sepsis. Absorption. These studies are important in uncovering underlying autoantibodies in those patients who have a history of pregnancy or transfusion, if time allows for this study. In those who have not been transfused or pregnant in the preceding 3 months, an autologous absorption is indicated. Absorption, and you can see here a graphic representation of the processing of the eluate to perform these auto absorptions. The green boxes are the antigen represented there, The autoantibodies are yellow dots, and the alloantibody will be the blue dots. You can see when you look, the antigen are still attached to the red cells, and all the autoantibodies or alloantibodies will be in the supernatant. Then you can do autoantibody adsorption to the patient's red blood cells, and then what is left in the supernatant will be the alloantibodies, if any. In phenotype, this can be used to select units of blood for transfusion that will prevent alloimmunization, and can also be used to avoid antigen pre-exposure if the patient is already alloimmunized, but with undetectable levels of the antibodies at that time. Such a strategy will generally preempt the need to perform adsorption studies. So if you have this technology, this is very useful, and in our labs we have the option in some cases. Looking into genotype, this may be particularly important in those cases with in which a clean phenotype cannot be obtained, usually as a result of insufficient dissociation of autoantibodies from the red blood cell membranes. Elution. Typically, if the plasma demonstrates a pan-reactive antibody, the eluate will confirm the same, but the reactivity actually will be stronger due to the concentration of the eluted antibody. A negative eluate may be indicative of a drug-dependent antibody, since the implicated drug must be present in the test for the antibody to react. Here we can see some antibody elution methods that can be helpful depending on what you're looking for. For example, the Louis Freestyle can be used for ABO in hemolytic disease of fetus and newborn. It's quick, a small volume of red cells are needed, but poor recovery of other antibodies. And you can see the other options that you may need in your practice. When we look at the serologic findings of autoimmune hemolytic anemias, we can see comparing the different types with the laboratory results, including DAT, immunoglobulin type, eluate, serum, and the specificity. As we mentioned before, the warm hemolytic anemias are the most common ones. And when you look at the DAT, you may have IgG or IgG plus complement or complement alone. So the most common reactivity you will see in about 2/3 of them is going to be IgG with complement. Then the second one will be about IgG only, about 20%. And the least common time you will see complement only. The immunoglobulin type in these cases are IgG, and the eluate will show the IgG antibody. The reactivity is strongly reactive, multiple specificities is reported. Then you have the cold agglutinin syndrome, which is complement only, and it's, you can see in the immunoglobulin type as IgM. And then the eluate should not be reactive. And in the serum, you will see IgM agglutination antibody. The titer could be above 1,000 in many cases at 4 degrees Celsius. And if they actually react above 30 degrees as well in some cases. And the specificity usually is anti-VGAT. Then you have a mixed type, which is a mix of the two previous mentioned ones. And you also may have the paroxysmal cold hemoglobinuria, which is a complement only. It's actually an IgG. We saw the cold agglutinin was IgM. The eluate is not reactive. The routine IAT is negative. The IgG is by basic hemolysin in Donovan standard test. So that's one of the tools that we can use. And the specific will be the anti-P. This is to expand a little more on the previous slide. You can see here the percentages that we mentioned in warm hemolytic anemias. And also you have here an expansion talking about the drug-induced immune hemolytic anemias, where you can see how the DAT reacts, what you will see in the serum and in the eluate. Transfuse incompatible red blood cells. In the end, incompatible units associated with warm reactive antibodies should be transfused judiciously, knowing that as long as the antibodies are being investigated, these units should have the same survival as the patient's own red blood cells. It's just a reminder for the clinicians. The management This is again for the transfusion side. They can use steroids, then IVIG or immunosuppression with one of these medications may be helpful. If that doesn't work, then they can go to surgery and take the spleen out in refractory cases. And finally, the last option will be autologous stem cell transplantation that has been used in very extraordinary cases. In summary, patients with warm-reactive antibodies are challenging, but with a little extra effort in the front end, they can be managed successfully. The laboratory and the clinical team can be confident that units released for transfusion, although they are incompatible, have high likelihood of being safe and efficacious for the patient, transfused when clinically indicated, and give the minimum volume of red blood cells that is expected to confer clinical benefit slowly, 1 unit over 4 hours, evaluate the patient, and if needed, continue with more transfusions. These are some extra references that I used for this presentation. You can feel free to review them. I thank you for your time. In this micro image, we can see a time lapse of monocyte in the peripheral smear, capturing and phagocytizing bacteria, a cocci. Thank you very much for your time.